Dentists hear the same frustrating story. Patients swear they brush twice a day, yet present with persistent plaque and bleeding gums. While the daily habit of brushing is deeply ingrained from childhood, it's often executed with an outdated mindset regarding the physical tools themselves. Early attempts to automate the process failed. Merely adding a power cord didn't address the mechanical reality of how a brush removes plaque. This persistent failure rarely comes from a lack of effort. It happens because we match the wrong mechanical tool with the wrong physical technique. Walk down any pharmacy aisle and it's easy to assume all manual toothbrushes are identical commodities, simple handles with bristles attached. Achieving clinical success requires looking past the plastic handle and selecting a tool based on a specific individual prescription. When the mechanical design is inherently mismatched to a patient's anatomy, the most diligent daily routine can still fail to control plaque accumulation. To understand this, look at the brush head's macro-anatomy, divided into the toe at the extreme end and the heel near the handle. The surface isn't a uniform block. It's composed of distinct bristle groupings called tufts. Standard adult brush heads contain between 19 and 38 tufts. Within each tuft, individual filaments must fall into a strict structural window, between 150 and 400 micrometers in diameter. Evaluating how these microscopic filaments interact with human tissue requires a level of analysis that goes far beyond what is visible in a bathroom mirror. Variations of just a few micrometers in these filaments dictate whether a brush can successfully enter the interproximal spaces between the teeth. While this macroanatomy provides the baseline, it is the microscopic tip of each filament that ultimately determines if the gingiva is being cleaned or slowly damaged. At the microscopic level, the safety of a toothbrush is determined by the shape and texture of the bristle tips. This scanning electron microscope image reveals the physical reality of these tips. By measuring the diameter of these specific tips, researchers can evaluate the stiffness and flexibility of the brush when it's under load. They also verify manufacturing consistency by counting the individual filaments within a single tuft to ensure the brush meets its design specifications. To classify these shapes, clinicians use the Adrian's grading scale. It's a geometric sorting system that separates safe, rounded tips from those with irregular, sharp edges. Category 1 and 2 are the acceptable morphologies, bristles that are either perfectly round or flat with rounded rims. These rounded shapes are designed to glide harmlessly over soft tissue, even when a patient uses an aggressive brushing technique. In contrast, categories 5 through 7 encompass unacceptable shapes, jagged, knife-like, or mushroom-shaped tips that never received proper end rounding. These unrounded edges induce micro-abrasions on the gingiva, leading to chronic inflammation and tissue recession. A significant portion of manual toothbrushes currently on the market fail this microscopic evaluation, despite their commercial availability. A brush can boast high tuft counts and ergonomic handles, but if the microarchitecture is jagged, the patient is unknowingly scarring their gums every single day. Beyond the individual bristle, the overall arrangement of these tufts, known as the brushing plane, governs how the tool navigates the mouth. Standard flat-trimmed bristles are prone to the blocking effect. Because the teeth have varying heights, the longer surfaces physically block the bristles from reaching the deeper baps between them. Multi-level bristle designs bypass this by using varying lengths, allowing the longer tufts to penetrate those hidden gaps, while the shorter ones clean the exposed surfaces. The rippled or zigzag design takes this a step further, mapping the bristles to the naturally scalloped alignment of the teeth. The angled or crisscross design uses a unique mechanism where tufts pivot independently. This allows them to sweep into deep crevices from multiple directions without being obstructed by the adjacent tooth. Clinical evidence confirms that these crisscross designs provide the highest plaque removal efficacy for manual brushing. Power toothbrushes offer a different mechanical advantage: sheer stroke velocity. A manual brush typically moves at about 300 strokes per minute. A rotation oscillation power brush generates between 2,500 and 7,500 strokes in that same window of time. Cochrane reviews show that this rotation oscillation mechanism is more effective than side-to-side actions for reducing gingivitis over the short term. Whether manual or powered, a flat plane is anatomically inadequate. The brushing surface must be engineered to match the uneven topography of the human mouth. Given these microscopic variables, dental professionals must move away from generic advice and begin formally prescribing the specific tool each patient needs. Prescribing a toothbrush is exactly like prescribing orthotics. The correct fit depends entirely on the unique anatomy of the user. For a healthy adult, the ideal prescription is a compact head with soft bristles arranged in a crisscross brushing plane. A pediatric patient in mixed dentition requires a staged brushing plane, extra soft filaments, and a cushioned head to protect developing tissue. Elderly patients or those with limited manual dexterity should be prescribed a rotation-oscillation power toothbrush to compensate for reduced mechanical input. Orthodontic patients need a bi-level or V-shaped brushing plane that is specifically cut to fit over their brackets and wires. Finally, for patients with receding or sensitive gingiva, the intervention must be an extra soft, flat plane with strictly round-tipped filaments to prevent further abrasion. Matching the micro-architecture of the brush to the patient's unique oral landscape is not a suggestion, it is a clinical necessity. However, even the most precise prescription is only effective when paired with correct behavioral compliance. Practitioners should stop relying on the phrase "brush twice a day" and instead explain the physiological reason why timing matters. This data shows the natural drop in salivary flow during sleep. Saliva is our primary defense against bacteria. When it disappears, bacterial acid production spikes. Skipping the nighttime brush gives bacteria an 8-hour window of uninterrupted acid production, drastically increasing the risk of decay. Patients also need to understand the most frequently ignored post-brushing instruction. Spit the toothpaste out, but do not rinse. Rinsing with water immediately after brushing washes away the active fluoride before it has had any time to remineralize the enamel. Proper technique involves angling the bristles 45 degrees toward the gum line, the modified Bass technique, and maintaining that action for a full 2 minutes. To ensure compliance, practitioners should ask for a teach-back, requiring the patient to demonstrate their technique in the chair before they leave. The toothbrush is a precision medical device, but it only works when prescribed accurately and operated correctly. Practitioners are the essential bridge between design science and the patient's health.